Dear friends, in this video, we are going to discuss about perioperative anticoagulation management, a topic which is more important for the trainees of anesthesiology in comparison to critical care. But nevertheless, this is a very important topic, not only for its practical implications, but also a very important topic at all levels of MD and DM examinations in anesthesiology. So let us start with this illustration of a 54-year-old male with subacute intestinal obstruction and signs of peritonism, who has a history of acute MI 3 months ago and was put on and underwent stenting with a drug-eluting stent, and who has also a history of stroke 1 year ago. And patient is presently on the prescription of dual antiplatelet, telmisartan 40 mg OD, metoprolol extended release 50 mg OD, rosuvastatin, and dabigatran. On examination in the CECT abdomen, there are adhesions and narrowing in the jejunum with free fluid in the peritoneum, and that calls for exploratory laparotomy to release those adhesions and also send for biopsy. And thereafter, the patient is planned for an exploratory laparotomy. Now, how to maintain anticoagulation in the perioperative period in similar patients? So any approach of therapy towards perioperative anticoagulation is based upon 4 considerations. The first consideration is risk stratification of patient-related and procedure-related risks of thrombosis and bleeding. Although thrombosis and bleeding are two diametrically opposite phenomenon, there are many patients in whom there are risks of both occurring. For example, patients with liver diseases. We know that they are already in a prothrombotic state, and yet, because of the deficiency of certain factors which are related to coagulation, they are also at the risk of bleeding. So, in patients who are at the risk of thrombosis, they may also be at risk of bleeding if the drug which is used as for antithrombotic measure is given in excess, or if the procedure which is performed emanates such a situation where bleeding exceeds the expectation of the surgeon. So the risk of thrombosis and bleeding needs to be weighed individually. The clinical consequences of thrombotic or bleeding event, which means that whether and which, if out of the two, is likely to be more life-threatening. Discontinuation and reinitiation of anticoagulant therapy on the basis of the pharmacokinetics of the chosen agent. So all the agents will have a different behavior in terms of absorption, metabolism, distribution, and elimination. And therefore, their discontinuation and reinitiation has to follow the property of the particular drug or agent. And whether aggressive management, such as the use of periprocedural heparin bridging, has advantages over the prevention of post-operative thromboembolism. Now, what is this heparin bridging? We will try and discuss in subsequent slides, but it needs to be seen that whether such bridging is likely to have an advantage on the patient on a case-by-case basis. If we look into the American College of Chest Physicians score, they have chest guidelines. They suggest risk stratification for perioperative thromboembolism based upon 3 considerations. 1, what is the is there any mechanical heart valve? And if there is, what is the type? If the patient is having any atrial fibrillation, and if the patient has or had venous thromboembolism. Now, this risk is categorized into high, moderate, and low. High, if there is more than 10% per year risk of arterial thromboembolism, or more than 10% per month risk of venous thromboembolism. Now, what are the patients who fall under the high risk category? One, if the mechanical heart valve, if there is any mechanical mitral valve, if there is a caged wall or a tilting disc valve in the mitral or aortic position, and if there is recent stroke or TIA. By recent, we mean within past 6 months. Again, in terms of atrial fibrillation, the risk category is high. If the CHADS2 score is of 4, 5 or 6, we will come to the CHADS score in the subsequent slide. If there is recent stroke or TIA within less than 3 months, which was earlier 6 months, here it becomes less than 3 months in presence of atrial fibrillation, and rheumatic valvular heart disease. Thirdly, on the basis of venous thromboembolism, the risk is considered to be high if there is recent venous thromboembolism within 3 months, if there is severe thrombophilia, if there is deficiency of protein C, protein S, or antithrombin, antiphospholipid antibodies, or multiple thrombophilias. So all of these constitute the high risk category based upon 3 aspects: the mechanical heart valve, the atrial fibrillation, and venous thromboembolism. The risk is moderate when the risk of arterial thromboembolism is 4 to 10% per year, or the risk of venous thromboembolism is between 4 to 10% per month. So again, we consider the same factors, that is the mechanical heart valve. So if it is a bileaflet AVR with major risk factors for stroke, the risk is moderate. If atrial fibrillation corresponds to a CHADS2 score of 3 or 4, the risk is moderate. And if the venous thromboembolism has occurred within the past 3 to 12 months, and if there is recurrent venous thromboembolism, non-severe thrombophilia, or active cancer, then also the risk of perioperative thromboembolism is moderate. And the risk is low when the risk of arterial thromboembolism is less than 4% per year, or the risk of venous thromboembolism is less than 2% per month. In consideration to the mechanical heart valve, the bileaflet AVR without major risk factors for stroke is a low risk. CHADS2 score of 0 to 2 for atrial fibrillation with no prior stroke or TIA is low risk. And in venous thromboembolism perspective, if the venous thromboembolism is more than 12 months ago, then the risk is considered to be the low. Now, this is a very useful means and a very logarithmic way of defining or identifying the risk category of the patient. Now, coming to the CHADS2 score, the CHADS2 considers a total 6 is the maximum score in CHADS2, and it is the risk factors are congestive heart failure, hypertension, age over 75 years, diabetes, each with a score of 1, and previous stroke or TIA gets a point of 2. So out of this 6 point, CHADS2 score is given. So there is another score, which is a modification of the CHADS2 DS2 VASC score, where in addition to all those previous points, one more point is given to age. So which was 1 in CHADS2 score is 2 here in CHADS DS2 VASC score. In addition, the presence of vascular disease, age between 65 to 74, and female categories are in addition given extra points. So the previous score, which was 6 maximum in CHADS2, becomes 10 maximum with CHADS DS2 VASC score. And this use of CHADS DS2 VASC score markedly improves the classification of atrial fibrillation patients who are truly at low risk of stroke compared with the commonly used CHADS2 score, because it gives those additional points which may actually be missed out in the CHADS2 score. Now, that was the risk of thromboembolism. Now, how to determine the bleeding risk during surgery? Here also there is a score which is called the Hasbled score. H stands for hypertension, score is 1. A stands for abnormal renal or liver function. 1 point is attributed to each. So the score will be 1 or 2 depending on the affection of either renal or liver or both the organs. S stands for stroke. B stands for bleeding. Labile INR stands for 1, which is fluctuating. Elderly, that is age more than 65 years, is also assigned a point of 1. And drugs or alcohol, if the patient is either on drugs or alcohol, then that again gets a point or 1 or 2, depending on presence of one or both factors. So a Hasbled score of more than 3 indicates a high bleeding risk. In addition to that, we know that there are certain surgical procedures which carry low risk of bleeding, and some surgical procedures have high risk of bleeding. So the low risk ones include minor procedures, the dental extractions, endodontics, cataract removal, joint injections, abdominal hernia, etc. Whereas more extensive abdominal surgeries or surgery in highly vascularized organs like kidney, liver, spleen, heart surgeries, brain surgeries, spinal surgeries, orthopedic surgeries, or surgeries for longer duration of time all poses a significantly higher risk of bleeding. So among the surgical procedures, intracranial, cardiac, and neuraxial procedures are of special concern because of the localization of the potential bleeding to a particular compartment and poor patient outcomes in the presence of this complication. So this is also an important consideration in such patients. Now, how to determine whether or not to interrupt an anticoagulation therapy if the patient is already on one like ours? Now, the optimal management is only achieved through a balance between the thromboembolic and the bleeding risks. Which one outweighs the other? Patients with high risk of bleeding will benefit from anticoagulation interruption. Patients with high risk of thromboembolism may benefit from bridging therapy and the shortest period of anticoagulation withdrawal. So if we follow these principles, then we are unlikely to miss out the patients in whom this therapy needs to be continued or discontinued and eventually run the risk of complications. So how to plan surgery in patients with dual antiplatelets? Because most of the patients who are stented with drug-eluting stents are on dual antiplatelets. So if aspirin and thienopyridine, like clopidogrel, they need to be withheld during the perioperative period for high risk of bleeding, elective surgical procedures should be delayed by 6 weeks for patients with bare metal stent and for 6 months for patients on drug-eluting stent. In case the surgery cannot be postponed, then the dual antiplatelet should be continued throughout the perioperative period. Now, if you see the guidelines, the 2016, the American Heart Association, Cardiology Association updated and modified the recommendations. Earlier, for drug-eluting stent, this was the window period was 1 year, and that 1 year, the window period has been reduced to 6 months. And it also considers operation after 3 months if the risk of delaying surgery is greater than the risk of stent thrombosis. Next, coming to what do we mean by bridging therapy? Bridging anticoagulation consists of substitution of a long-acting anticoagulant, usually with warfarin, for a short-acting anticoagulant, which is usually the low molecular weight heparin. So this limits the time of subtherapeutic anticoagulation levels, so reduces the risk of thrombosis and minimizes the thromboembolic risk. If we look into the original bridge study design, you can see here that the patients were screened 30 days before surgery. You watch to your left, the patients were stopped on warfarin 5 days prior to surgery. And after that, 3 days prior to surgery, in one group, dalteparin, which is a low molecular weight heparin, was started, and in another group, the placebo was started. And 1 day before surgery, both were discontinued. Thereafter, dalteparin or placebo was resumed within 24 hours after the procedure in patients who underwent a procedure which is associated with low risk of bleeding, and in patients who underwent a procedure associated with a high risk of bleeding, either dalteparin or placebo, was reduced for 48 to 72 hours after the procedure. And these patients were followed up over a period of time, and the study was stopped when the INR reached the therapeutic range, and the results were compared. So in total, around 1884 patients were enrolled, of which 950 were assigned to receive no bridging therapy, that is, they continued on placebo, and 934 were assigned to receive bridging therapy. The incidence of arterial thromboembolism was comparable. It was 0.4% in the no bridging group as against 0.3% in the bridging group. But the incidence of major bleeding was 1.3% in the no bridging group and almost 3 times nearly 3 times in the bridging group, that is 3.2%. So although this study was criticized for exclusion of high thromboembolic risk patients, but it was sure that this procedure might also cause a lot of harm in patients who have high risk of bleeding. So there were major studies which compared bridging to no bridging periprocedural strategies in patients receiving warfarin. So some of them were observational and 2 were RCT, and 1 meta-analysis was there, but this meta-analysis was published long back. So if you see the Periop-2 trial, which considered the patient population with mechanical heart valve and atrial fibrillation, and they compared both the bleeding and the thrombosis in patients who were on bridging versus placebo, they did not find out too much of benefit with the bridging therapy. So therefore, despite the growing evidence about the limited to non-existent benefits of bridging therapy, it is still being used on a case-by-case basis, because in some patients, it has been found to give exceedingly good result, and also their numbers are less, but their effect is long-lasting. So how to bridge? In the preoperative period, we have to discontinue warfarin 5 days before the surgery, and 3 days before the surgery, start subcutaneous low molecular weight heparin or unfractionated heparin, depending on the renal function of the patient at therapeutic doses. 2 days before surgery, assess the INR. If it is greater than 1.5, then we have to administer vitamin K in a dose of 1 to 2 mg. And we discontinue low molecular weight heparin 24 hours before surgery, or 4 to 6 hours before surgery in case of unfractionated heparin. In the postoperative period, if the patient is tolerating oral intake and there are no unexpected surgical issues that would increase the bleeding risk, then we can restart warfarin 12 to 24 hours after surgery. If the patient received preoperative bridging therapy because having high thromboembolic risk and underwent a minor surgical procedure, we can resume the low molecular weight heparin or unfractionated heparin 24 hours after surgery. If the patient underwent a major surgical procedure, we have to resume low molecular weight or unfractionated heparin 48 to 72 hours after surgery. And it is always important to assess the bleeding risk and adequacy of hemostasis before resumption of low molecular weight heparin or unfractionated heparin. So it is important to see for the surgeons that if they are comfortable with their surgery, and if they see that whether the tissues have a greater tendency to bleed, so if they can give an opinion, the same should be considered. So the 89 guidelines agree with the ASRA 2018 guidelines, and they are also similar to the American College of Surgeons 2018 guidelines. Now, how to manage patients who are on direct oral anticoagulants and their therapy and are undergoing surgery? So bridging therapy is not indicated in patients who are on directly acting oral anticoagulants. Timed interruption of anticoagulant therapy before surgery is desirable, and the appropriate timing interruption for patients on directly acting oral anticoagulants is based on the invasive and the bleeding risk of the procedure, the pharmacokinetic profile of the agent, and the clinical characteristics of the patients like their liver functions or kidney functions, and where the elimination and the metabolism of the drug or the compound is taking place. So directly acting oral anticoagulants should be held 3 half-life times before low-risk procedures and 5 half-life times before high-risk procedures. So if you consider rivaroxaban, apixaban, indoxaban, if the risk of bleeding is high, you stop 2 days before. If the risk of bleeding is low, we can stop 1 day before surgery. For dabigatran, again, the risk can be low and high. We have to look in additional for the creatinine clearance. If the creatinine clearance is more than 50, stop 1 day before. If it is less than 50, stop 2 days before. If the bleeding risk is high and the creatinine clearance is also high, stop 2 days before. If the bleeding risk is high and the creatinine clearance is less than 50, then stop 4 days before the surgery. So restarting is equally important because in the post-operative period, the same patients who were at risk preoperatively are at increased risk. So the timing of directly acting oral anticoagulants should also be based upon consideration is before surgery. So we have to restart anticoagulation around 6 to 8 hours after surgery for low bleeding risk and 48 to 62 hours after surgery for patients with high bleeding risk. And always remember that patients, if have a creatinine clearance of less than 15 mL per minute, this patient should not be on directly oral anticoagulant therapy, and therefore it is good to remodify the treatment. Now, how to perform an emergency reversal of anticoagulation? An urgent procedure is one which is defined as one that can be delayed up to 24 hours, giving time to the physician to conduct anticoagulant reversal based on repeated coagulation tests. An emergent scenario is one in which the patient requires surgical intervention in less than 1 hour or is experiencing life-threatening bleed. So in emergent cases, the amount of time, the number of coagulation tests that can be performed and the opportunities to delay the procedure until the bleeding risk is lowered are absolutely limited. So therefore, reversal of warfarin for non-significant bleeding with alterations of INR, we go for conservative strategies such as interruption of the drug and oral vitamin K. In emergent scenario, the reversal of warfarin anticoagulation is based on prothrombin complex concentrate and FFP administration. And this dosing is based upon the INR levels. If it is between 2 to 4, then prothrombin complex concentrate of 25 international units per kg for IV. And as it increases to 4 to 6, 35, and then for more than 6, it is 50. In addition, vitamin K and fresh frozen plasma. In trauma patients, 1 gram of tranexamic acid can be used at arrival and a repeat dose of 1 gram at 8 hours apart. We have to remember that PCC is contraindicated in patients with a past medical history of HIT, heparin-induced thrombocytopenia. If we want to look into the reversal of the directly acting oral anticoagulants, then you find that there are either we can use the specific anticoagulant, that is either idrasuzumab or adnexanet alpha. Although siraparantag is available in some places, it is still not available in large number of countries, including ours. And rivaroxaban, apixaban, betrixaban, fondaparinux, all of them can be reversed by adnexa, that is adnexanet alpha, which is a recombinant factor 8A, whereas idrasuzumab is specific for dabigatran, which is a humanized monoclonal antibody. 2 doses of idrasuzumab, 2.5 mg, is given maximum 15 minutes apart, and it may need extra dose after 12 to 24 hours. Onset is with less than 5 minutes, and the duration of action is 24 to 72 hours. So with Adnexate alpha, that is a single IV bolus dose, that is 400 to 800 mg, continuous infusion up to 2 hours or at a rate of 4 to 8 milligrams per minute. You have to remember that for several years, the first line option for the reversal of anticoagulation was the PCC, prothrombin complex concentrate, but evidence about PCC is controversial now, and with the approval of new specific reversal agents or medications, its future use is quite uncertain. Next, important is what are the considerations for patients undergoing neuraxial anesthesia? For patients treated with unfractionated heparin, the infusion should be interrupted 4 to 6 hours before puncture or catheter removal or manipulation. If the patient is receiving unfractionated heparin subcutaneously, then the drug should be interrupted 8 to 12 hours before puncture or catheter removal or manipulation. Independent of the route of the unfractionated heparin, be it IV or subcutaneous, the drug can be restarted 1 hour after puncture of the or catheter removal or manipulation. Patients who are receiving a prophylactic dose of low molecular weight heparin, the drug should be interrupted for 12 hours before puncture or catheter removal or manipulation, and 24 hours if the dose is therapeutic. And independent of the low molecular weight heparin dose, the drug may be restarted 4 hours after the puncture, which was 1 hour in case of unfractionated heparin. Here it is 4 hours after the puncture or catheter removal or manipulation. So to summarize, we find that first question that need to be asked in all such patients is that whether there is interruption of anticoagulation is needed. The answer may be no, in which the intervention would be either to continue the anticoagulation, pacemaker implantation, dental extraction, cataract surgery, dermal skin procedures, all those things follow that, or the answer may be yes. So if the answer is yes, then the next question to ask for is whether bridging anticoagulation is needed. So if the answer is no, then stop warfarin 5 days before the procedure. If the answer is yes, that is high stroke risk, recent DVT, high risk mechanical heart valves, then use the therapeutic low molecular weight heparin BID for 3 days before surgery. The last preoperative dose 24 hours before surgery, which is half of the daily dose. Resume the low molecular weight heparin 48 to 72 hours after surgery, and post-operatively warfarin you consider the bolus dose when you start warfarin. So always remember to seriously consider whether there is a real need to stop anticoagulation for the scheduled procedure, both on account of the patient-related risk factors and the procedure-related risk factors. Not to use low molecular weight heparin to bridge direct oral anticoagulants, not use therapeutic low molecular weight heparin the night before procedure, always use prophylactic, and when bridging, use a delayed initiation of full dose anticoagulation in high risk patients. Thank you very much.